Welcome to this complete explainer on aqueductal stenosis. We're going to break down the pathology, the diagnosis, and the treatments point by point. We're seriously leaving absolutely no stone unturned here. So if you've been looking for something that clears up your concepts entirely, without making you dig through a super dense medical textbook, you are in the exact right place. Let's just get right into it.
Okay, here's our agenda. We'll move sequentially from the basic definition and anatomy right into etiologies, how this presents in both infancy and adulthood, and then wrap up with evaluation and treatment options.
Section 1. Definition and anatomy. Let's establish exactly where this blockage occurs.
So the crucial starting point here is understanding the normal pathway. The Sylvian aqueduct is essentially this narrow little channel that acts as a transit corridor. It moves cerebral spinal fluid, or CSF, from the third ventricle down to the fourth ventricle. Aqueductal stenosis, or AQS for short, is exactly what it sounds like. It's a physical narrowing, or sometimes even a complete rigid blockage of this very specific pathway.
Think of it like a plumbing backup. Because the fluid is produced upstream of the blockage, the pressure just builds and builds, and it balloons out the cavities above it. This results in what we call triventricular hydrocephalus, meaning the two lateral ventricles and the third ventricle become, well, massive. But, and here's the kicker, if you look downstream, below the blockage, the fourth ventricle remains completely normal in size. It is an absolute hallmark of this condition.
Section 2. Etiologies. Let's look at the actual causes of the blockage.
First up, congenital malformations. This just means the patient is born with a structural anomaly. Now, it doesn't usually happen in isolation. You'll frequently see it running alongside other major neurological conditions, specifically Chiari malformations, which is where brain tissue extends down into the spinal canal, or neurofibromatosis, which is a genetic disorder that causes tumors to form on nerve tissue.
On the flip side, acquired causes happen later in life due to some external factor. Inflammation is a really major driver here. We're talking scarring from a previous hemorrhage or maybe a severe infection. We also see neoplasms, tumors, which can physically press on and just choke off that aqueduct entirely. And finally, specific arachnoid cysts located near the quadrigeminal plate can also compress this delicate little fluid channel.
Section 3. Infancy presentation. Let's talk about congenital hydrocephalus.
The sheer scale of this issue in pediatrics is honestly striking. Aqueductal stenosis accounts for up to 70% of all congenital hydrocephalus cases. Let that sink in. It is a massive, dominant factor anytime you're evaluating an infant with excessive brain fluid.
And these pediatric patients usually don't have a delayed presentation. They typically present with hydrocephalus right at birth, or they rapidly develop it within their first 2 to 3 months of life. Genetically speaking, there's a really strong clue to watch for here. Congenital AQS can actually be driven by an X-linked recessive gene. That's a super vital piece of information when it comes to family planning and genetic counseling.
Now, if we look under a microscope, we actually see 4 distinct anatomical types of congenital stenosis, famously described by Russell. First is forking. Basically, instead of one main pipe, you get these multiple, tiny, narrow channels separated by normal nervous tissue. Second is periaqueductal gliosis. This is a narrowing of the tube caused by an overgrowth, specifically a subependymal astrocytic proliferation. Third is true stenosis. Here, the aqueduct is structurally narrowed, but, surprisingly, under a microscope, the tissue looks totally normal. And fourth is a septum. This is a literal, solid physical membrane, a barrier, just totally blocking the tube. Regardless of the type, every single one of these halts that fluid flow.
Section 4. The adult presentation. Why it's so often overlooked and mistaken.
Now, pay really close attention to this because it's a vital diagnostic trap you want to avoid. Many adult cases of aqueductal stenosis completely masquerade as and are mistakenly diagnosed as normal pressure hydrocephalus, or NPH. Because the symptoms can look so similar on the surface, the true mechanical obstruction of the aqueduct ends up remaining entirely overlooked.
The timeline of these symptoms in adults varies pretty wildly. In one series of 55 cases, about 35% of patients had symptoms for less than a year before it was caught. But nearly half, 47%, suffered with symptoms for 1 to 5 years. The longest recorded duration was a staggering 40 years. No way, right? And while it generally follows a long-standing, more benign course, let's be clear, this is not a harmless condition. There are documented reports of elevated intracranial pressure suddenly spiking and actually leading to sudden death.
So what does the data actually show for adult patients over 16? Well, headaches are the undisputed primary symptom here, affecting 58% of patients. And these aren't just any headaches. They have all the classic characteristics of elevated intracranial pressure. Next up, you've got visual disturbances at 40%, usually blurring or loss of visual acuity. Then we see this whole cascade of neurological impacts. Mental deterioration sits at 31%, gait disturbances and frequent falling hover in the 20s, and interestingly enough, endocrine disturbances show up in 18% of cases. That can include things like menstrual irregularities, hypothyroidism, and hirsutism.
Now, when you actually conduct a physical exam on these adults, the objective signs really heavily reinforce that presence of pressure. Papilledema, which is the swelling of the optic disc due to increased brain pressure, that's the most common finding, seen in 53% of patients. You'll also frequently spot pyramidal tract signs, like mild weakness or spasticity in about 44%. Intellectual impairment is objectively measured in 36%. You might also see ataxia, and then, in smaller percentages, specific visual field defects, blind spots, or even anosmia, which is the loss of smell.
Section 5. Evaluation and MRI. How we confirm the diagnosis. When it comes to imaging, MRI is the absolute gold standard test of choice. Sure, a CT scan can show those enlarged ventricles, but you really need an MRI to view the aqueduct properly. And listen, here's the golden rule. You absolutely must administer contrast during the MRI. Why? Well, because you have to definitively rule out a tiny tumor, like a tectoglioma, acting as the hidden cause of the blockage.
Radiologists are essentially hunting for two major things here. First, the absence of the normal flow void. That's radiologist speak, meaning they just can't see the dark signal of fluid actively moving through the aqueduct. Second, they look for a classic radiological sign called funneling, and this looks exactly like what it sounds like. The upper part of the aqueduct widens out and then tapers down into a sharp point right where that obstruction sits.
Section 6. Treatment options. How we bypass the blockage. Historically, surgeons actually tried treating the primary lesion itself, like trying to break open the septum, but that approach has largely fallen out of favor. Today, it's all about highly effective fluid diversion. We rely really heavily on endoscopic third ventriculostomy, or ETV, which essentially creates a brand new bypass pathway. There's also traditional CSF shunting, where a tube drains the fluid down to the peritoneum or the vascular system. Finally, there's a really specific technique called a Torkeldsen shunt. This routes fluid from the lateral ventricle down to the cisterna magna. It works particularly well in adult cases, though. For context, pediatric patients often don't have a developed enough subarachnoid space for it to function properly.
Now, the care definitely doesn't stop in the operating room. Even after a highly successful ETV or shunting procedure, medical protocol dictates mandatory follow-up. You have to actively track the patient for a minimum of 2 years. Think of it as a safety net to ensure that a very slow-growing, occult tumor doesn't suddenly reveal itself later as the true initial cause of the stenosis.
So, we've covered the complete picture, from the deep anatomical subtypes described by Russell right through to the specific MRI funneling signs and the Torkeldsen shunt, and it really leaves us with a fascinating, almost haunting thought to ponder. When an adult walks into a clinic with sudden, severe headaches and visual disturbances, could it simply be a microscopic anatomical quirk? Just a silent childhood anomaly that patiently waited decades before finally waking up to make itself known? Understanding aqueductal stenosis means we can finally answer that call and intervene. Thanks for joining me on this explainer. I'll catch you next time.